Namaste. To understand antrochoanal polyp, let us first look at nasal polyp. Nasal polyp are painless, benign growths on the lining of nose or sinuses. They are the outpouchings of mucosa. They are abnormal, painless, and benign. We have two major types of nasal polyps. The first is ethmoidal, and the second is antrochoanal polyp. Let's look at antrochoanal polyp. The antrochoanal polyp arises from the maxillary antrum. The maxillary sinus opens into the middle meatus. From the middle meatus, it can go into the nasal cavity. It can be seen anteriorly, and when it goes posteriorly to the corona, it can further spread and can be seen hanging behind the soft palate. When we look at the pathogenesis, it goes into the corona. There, it can block the corona, resulting in nasal obstruction. This leads to rhinolalia clausa. Rhinolalia clausa is hyponasal voice or loss of nasal resonance in the voice. The antrochoanal polyp has three parts: the antral, the conal, and the nasal. The antral part is a thin stalk. The conal part is round and globular, and the nasal part is flat from side to side. Looking at the etiology, the exact cause is unknown. But nasal allergy coupled with sinus infection is incriminated. Antrochoanal polyp are seen in children and young adults. They are usually unilateral and single, whereas ethmoidal polyps are multiple. The patient presents with unilateral nasal obstruction. But as the polyp grows, it blocks the opposite corona also, and it can be seen hanging in the nasopharynx. So the obstruction becomes bilateral. Next, the voice becomes hyponasal and thick. The nasal discharge appears mucoid. And it can be unilateral or bilateral. Let's look at some signs and investigations. We can do anterior rhinoscopy and posterior rhinoscopy. On anterior rhinoscopy, we can see a large, smooth, grayish mass, which is covered with nasal discharge. On touch, it is soft and can be moved up and down with a probe. A large polyp may protrude out of the nostril and appear pink, congested. As the polyp grows posteriorly, it may be missed on anterior rhinoscopy. So we do posterior rhinoscopy in this case. On posterior rhinoscopy, we may see a globular mass filling the corona or the nasopharynx. And if it is again large, it may be seen hanging down behind the soft palate and present in the oropharynx. Then, if we do examination of nose with endoscope, we can see the polyp hidden posteriorly in the nasal cavity. These are the investigations that we can do. Next is the differential diagnosis. We have three DDs here. The first is a blob of mucus. How are we going to distinguish between mucus and polyp? Mucus disappears on blowing the nose. Polyp won't disappear. The second DD is a hypertrophied middle turbinate. The hypertrophied middle turbinate will be pink in color, and on probe test, it will give a hard feel of bone. Also, we won't be able to rotate the probe all around the hypertrophied turbinate, whereas we will be able to do so for an antrochoanal polyp. The third DD is angiofibroma. Now, a patient with angiofibroma will present with profuse recurrent epistaxis. And angiofibroma will be firm in consistency, and it also easily bleeds on probing, whereas polyp rarely bleeds. Second, the consistency is soft in polyp. Next, we have other neoplasms. Now, the neoplasms can be differentiated as neoplasms are fleshy pink in appearance, they are friable, and they have a tendency to bleed. Now, here we have a coronal MRI section of the paranasal sinuses. Notice that there is a large soft tissue mass occupying the maxillary sinus. And then a polyp arises from this maxillary antrum and it has reached the nasal cavity. So I've shown an MRI in this pic because in MRI you can see the soft tissues better and it is easier to learn things. But generally we can do X-ray. X-ray of the PNS. In X-ray of the PNS or in the lateral view, we can see the globular swelling in the postnasal space. Now in treatment of antrochoanal polyp, first we do medical management, then we do surgical management. But it is very important to understand that the definitive treatment is surgical management and medical management is only supportive and it is to treat the symptoms. In medical management, first we do nasal saline irrigation. Now we are doing this to help clear the secretions and the crusts. Next, now to reduce the inflammation, we give intranasal corticosteroid sprays. Now both of these treatment is just supportive. The definitive treatment, the treatment of choice, is FES, that is functional endoscopic sinus surgery. In FES, we remove the entire polyp. We also remove the antral component so that it does not recur. Antrochoanal polyp rarely recurs, but if it recurs, then we have to do Caldwell Luck operation. This operation is rarely used now. It may be considered in selected recurrent cases only, especially in adults. We are done with antrochoanal polyp, but let's cover this one topic here, that is the common causes of unilateral nasal obstruction. Now, the obstruction can be in the vestibule, it can be in the nasal cavity, or it can be in the nasopharynx. We are discussing this here because a patient with antrochoanal polyp is presenting with unilateral nasal obstruction. So the vestibular causes are furuncle, vestibulitis, stenosis of nares, atresia, papilloma. In nasal cavity, the causes can be foreign body, deviated nasal septum, that is DNS, hypertrophic turbinate, concha bullosa, synecdoche, rhinolith. And in nasopharynx, it can be unilateral conal atresia. So these are the causes. We are done with antrochoanal polyp, and you can get the notes on my threads account, which I have pinned down in the comment section. Thank you, and please subscribe for more such videos.